Our next speaker is Peter Graham. Peter Graham's also from the QAP. He's the head of the blood disciplines, and Peter's going to talk about point of care. His topic is entitled Point of Care Unleashed, Unravelling Point of Care Testing Management. Thank you, Peter.
Thanks, Tony, and thank you to Derek for our IT support. And also thank you to the organisers for the opportunity to present to you today. What a great turnout, so thank you. So I'm going to talk on point of care. The title proved to be a bit challenging, actually, but it's had its benefits as well. So just an outline of what we're going to try and cover is point of care testing unleashed, planning, unravelling, implementing, evaluating, QC, EQA, and some case studies. I don't have a good feel for how much point of care you manage in your laboratories or hospitals, and Australia's in all different formats as well, but let's work through it. So point of care, you might have a blood gas machine in your laboratory, but point of care is when you've got a blood gas machine in the emergency department or in intensive care. It could be, as we know these days, COVID, rat testing, pregnancy testing. There's a lot of self-testing, and that's growing in point of care, HIV. In pharmacies, they're taking over a lot of testing, certainly in Australia. Paramedical ambulances obviously get a lot of benefit from point of care, aged care facilities. Rural remote is an incredibly important role for point of care, particularly in large countries with broad networks like Australia. It's invaluable in hospital wards for ED and ICU, and also in workplace drug testing, for safety for people that are driving heavy equipment in coal mines, certainly in Australia. The technology has developed rapidly over the years, and pretty much it can cover any chemistry, immunoassay, PCR test. It's very sophisticated. You'll see me mentioning connectivity a few times today, and I think this is a very important part of point of care. There's a large range of tests that are covered by point of care: chemical pathology, hematology, microbiology, toxicology, infectious diseases. Microbiology covers all the PCR work. And there's certainly QC, the manufacturers will provide QC, but there's EQA available for all these programs. So point of care testing unleashed. Is it already out there in your organisation? Are you aware of it? Certainly when I worked at St Vincent's, we weren't aware of our X-ray department using inappropriate creatinine point of care, which was totally wrong results, and exposing patients to scans that may not have been appropriate. Is it controlled? Meaning, are patients potentially at risk? And there's various articles around the risk of lack of oversight and quality governance. This talks about mandatory regulation is needed to avoid harm, and this is in EU countries. So how do we manage risk? And here is an article recently in Australia where it's based on this survey. There's GPs, general practitioners, that are running HbA1c tests and for diagnosis and claiming in Australia we have Medicare rebates, but there doesn't appear to be good oversight of the quality of the results. So, as I've mentioned, point of care is very powerful, and I think you're the drivers. You can bring that care to patients by taking control. Here's just a few examples of the power of point of care. Hepatitis C, and the WHO is on an agenda to try and eliminate hepatitis C by 2030. That's ambitious, but they might be able to do it with point of care. We're also talking about the health dollar today, and just think about cost effectiveness. Point of care is disposable cartridges. It's never going to compete as a cost per test with your automated analyzers, but what is the overall benefit to the health dollar? And I think that's what we're trying to keep in mind here. So again, hepatitis C, you've got rapid PCR testing. It gives patients access to treatment who may not otherwise know that they are carriers of hepatitis C or that they have hepatitis C. And there's a cure, there's an outcome. There is treatment that will cure them and prevent it being passed to their children and other generations. And this is just an Australian example about, a very conservative estimate of the savings to the government, the Australian government, in their health costs. Like all countries, particularly as our diets have changed, the risk of diabetes has gone up substantially. It's one of our biggest problems, certainly in Australia, and it's certainly in every country, certainly across the world now. This was a recent article in The Star, and one of the initiatives there is to provide finger-pricked blood glucose tests across 700 community pharmacies. If that's abnormal, then refer that patient on for further testing. And that can pick up patients that are pre-diabetic, get them on the road to early interventional treatment. And as we've seen, the COVID-19 and, as Zoe's mentioned, the rapid rollout and development of rapid antigen testing, the lives that were saved, the hospitalisations that were prevented. And again, this is from an Australian study where conservatively, 1.8 billion just from keeping people at home and not taking up, the expense of intensive care. Towards health equity, and Australia is a big country, very remote regions, and Malaysia has similar challenges. We've got vulnerable populations. The cost of getting the patient to a medical centre, the cost of diagnosing a patient. So that you don't have the hospital facilities in all these sites. Certainly in Australia, if somebody has a chest pain in a remote area, is it stress or is it a myocardial infarct? And there's a process certainly in South Australia where that troponin result is done in the regions as a point of care. The results sent into the city, the cardiologists look at it and they say, yes, Medivac that patient at the cost of $25,000, or no, monitor them, they're fine. CRP for sepsis is a very valuable point of care test. As you know, HCG in a lady that may be pregnant, if they're going to have x-rays or interventions, and the hospital doesn't want to call a scientist in, they can do the test in the theatres before surgery. So again, we're talking 112 billion in savings. So just unravelling point of care testing and how you manage point of care. So if you're not already, talk to your clinicians. Ask them, does the time from when the blood sample is collected to when they get the result, is it meeting their needs? Is it meeting their patients' needs? Is it blocking your emergency department because patients are waiting for results before they can either be admitted or go home? Are they already using point of care devices that you don't know about? But you need the support of hospital management because certainly when I was at St Vincent's, pathology had their budget and the ED department had their budget. And trying to convince hospital management that it was better use of their dollar to have a blood gas machine in an emergency than sending them up to the lab is not easy in some cases, but agree on a policy. This is just a quick look at a study done amongst GPs in Scotland, I think, last year. And urinalysis, dipstick, pregnancy test, the finger monitor for oxygen saturation, blood glucose, obviously COVID rat tests have been out there for a long time. INRs, a lot of GPs use that to quickly make an adjustment to a patient's warfarin dose. Less in use are things like ketones, hemoglobin, as you go down the list, pro-BNP, which in some cases could be very useful, but is it too much in a GP setting? Also, just while it's in my head, blood ketones, you might only, in your laboratory, you might only get ketones once a month or once every second month. You don't want to have that assay on your main analyzer, QCing it and running, EQAs every well, EQAS is fine, but QCing it when you're not getting any patients, you could have a point-of-care ketone meter in your lab. When you get that odd request, you can do it on the spot, and it's a very cost-effective way of managing an assay that's, rather than having the reagent going off on your main analyzer. What would GPs like to have access to? So they want to keep all the pregnancy tests, they want D-dimers, they want strep A, hemoglobin, white cell count, a troponin in a GP setting. You should send the patient to casualty. What do they see the benefits of point of care? I think I'll just more focus on the bottom one there, which is that gives them more confidence about their clinical decision making. Planning a point of care rollout. There are guidelines. They guide on assessing the needs, look at the manufacturers, and fitness for purpose. There's CSLI guidelines, which are designed to implement a system that gives good quality management when you're managing non-laboratory personnel, and ensuring that the results are reliable and comparable to the laboratory, and the same quality principles apply as to laboratories, same ISO 15189. This is just an outline of the structure they recommend, and you've got the laboratory clinical consultant, but you need to have that interaction with the hospital. In Australia, there are guidelines for the GPs, and again, it's similar pattern. This is self-regulation because they're not under the oversight of a laboratory. You still need QC, EQA. You need to be competent and training and to get good patient outcomes. Some feedback from GPs in those settings helps them make life-saving decisions. It's vital for their everyday work. And accreditation's making sure that you're getting correct results. It gives you confidence in the results. There's a very good study that was done by the Malaysia Ministry of Health Assessment Unit, and they were looking for evidence around point-of-care testing. And so that was their objective. They compared devices to a central laboratory, and they outlined very similar implementation guidelines to the previous ones I've just shown you. And it was a very well done study, and they looked at the setting, point of care, primary care, GP setting, INR, it's comparable to a central lab, and there's evidence that it changes patient outcomes. A1C, interesting, is coming into focus more. The evidence was there that the devices are very comparable to mainframe laboratory tests, and there's good evidence that you've got the patient there and you can start, working on their treatment straight away. Urine dipstick's been around for a long time, but it doesn't give you the same quality of results. It's a screening test, it's semi-qualitative. So it's useful for guiding on some initiation of therapy, though, of urinary tract infection while you're waiting for the microbiology results to come back. Dengue in primary care, it's not very good at picking up IgM, so it's not going to pick up early detection, and they said the evidence wasn't sufficient. Full blood count, very comparable devices out there now, insufficient evidence. Emergency department, it's a value in this study, but insufficient. It's certainly comparable, but in terms of whether you need it compared to your laboratory. Electrolytes are having a rapid access to a potassium in an emergency department is critical. They looked at magnesium, but they didn't find any evidence. So implementing a point of care, and this is a stepwise approach, and again, there are guidelines out there. This is one that's come from our local NPAC group in Australia, and they interpret the ISO 15189 into point of care testing. As you can see, the structure is very similar. Determine the need, quality assurance, quality control, ongoing professional support. Training and competency is key. So determine the need. Will it improve patient outcomes? Will it expedite diagnosis and treatment? Are the clinicians and nurses on board will they embrace it? Or will they say, will the nurse say it's not my job? What tests would provide the maximum benefit? Is there an overall net saving? And it's there, you just need to put it there in a business case. Select the right device for your needs. There's lots of devices out there. Sometimes you can't get the test you want on one device. If you can get a device that covers a range of tests, it's less training, less oversight that's needed. If you're in an emergency, if you're looking after emergency departments or intensive care, they've got night staff that work at 2 a.m. in the morning. Your staff, if the vendor supports and goes in to train at that time of the night, it saves your staff having to go in at 2 in the morning, but be involved. And there should be access to only allow trained operators to use the devices. Okay, so again, you need to work with the manufacturers as well. Compare the results. There will be articles out there, but do some checks yourself. Check for bias and precision. Ideally, you use the same reference intervals for your point of care results that you use in the main lab, but if you can't, you can't. Troponin I, troponin T, and you need to be aware of the risks if you're doing a troponin I in the ED department and a T in your main lab, different units. It's quite critical that you don't confuse the clinicians. Okay, so I've mentioned connectivity a few times, and that's one of the major developments of point-of-care devices, and which helps you implement. Can they be connected to download results? Ideally with the operator ID. Can you monitor QC remotely? Can you troubleshoot? A lot of the blood gas instruments, you can order a recalibration with the QC fail in the emergency department from your main lab. So we talked a little about QC already. Checks your instrument's working, checks the operator is competent in this case, and gives them confidence in their results. And it checks for consistency between different lot numbers, although different lot numbers will usually, the QC will still work. EQA gives you more information on operator competency. As Zoe's already mentioned, it will pick up issues that QC missed, and the hemoglobin example is a prime one. It guides on accuracy. We've already talked a bit about the advantages and disadvantages in point-of-care settings. You've still got the real-time feedback, assuming the operator looks at the QC or does the QC, in which case it gives them confidence. It usually works. If it's not working, they've done something seriously wrong. The disadvantage is that the limits can be very wide or won't pick up a lot-to-lot variation, and commutability with QC and EQA, it's a very similar challenge. And again, we've talked about EQA can pick up issues that QC miss. A1C, it's pretty important when there's an accepted diagnosis of 6.5 that your DCA result gives the same result as the BioRad, because that patient's being nosed on that decision point. If you've got connectivity, you can access operator competency. And under conventional EQA, there can be some delays, and I think the example Zoe showed, and I think Tony and I are going to talk a bit more about real-time EQA. Okay, so you're into the evaluation stage. You need to monitor, assessing for operator errors. Here's an example of feedback from ambulatory care. We waste a lot of cartridges, overfilling, underfilling, bubbles, made a mess, let alone the waste. So follow up with operators, monitor the error rates, identify champions. If you've got a nurse educator in intensive care or casualty who's helping with the training of the staff, interested in the devices, sees the benefits. New South Wales Pathology uses a very nice system of connectivity, and they monitor the error rates amongst the operators. And if they see error codes, no sample, bubbles, insufficient, they target those operators for retraining. Again, QC, some devices, Gem Premiers, have internal QC, so you never actually, it's hard to see, you can, but you've got to dig deep into the software. You're assuming if it's not flagging a problem that all's good. Other devices like the radiometer, you can at least see what the QC is doing and perhaps pick up trends. Just a few case studies to finish up with. Hope we're not too far over time. Hemoglobin A1C, real-time EQA, and something we were just talking about at lunch yesterday, an experience I had at St Vincent's. Okay, so this is one we picked up earlier this year where the CVs on the DCA Vantage on both our lyophilized and our commutable whole blood program, which I think we also send to Malaysia, were unacceptable. And you can see the spread on the DCA results are these red dots here, but look at the spread of results. And it's even worse. Obviously, at high levels, it's worse. We contacted Siemens. Subsequent to that, they sent out a technical bulletin to all their, globally, and it was a calibration update. I checked with Siemens, did any other EQAs report that? And they said, no, it was our data that prompted, and they detected a lot number issue. And again, that to have a result decreased by 0.5, meaning it was 0.5 too high at a decision point, is not good. But the good news is they acted quickly. This was before the change, and the CVs were back in within 1 to 2 months as those lot numbers worked through the system. We do a lot of work with our quality assurance for Aboriginal and Torres Strait Islanders, our First Nations people. Australia's a big country. There's 200 Aboriginal medical services across the country, manned by Aboriginal health workers. We help with training the staff at workshops online, and there's dedicated staff in Adelaide that do online and go out and train. And the benefits of training is that where you're going to have a problem with a point-of-care device is the operator. If the sample's introduced correctly, you will get a good result. And again, type 2 diabetes is in a very bad situation with our First Nations people. It's 3 times higher than our non-Aboriginal populations. And the rate of dialysis is going up, and you can imagine in a remote community, someone having to present for dialysis. So if you can get early intervention, prevent kidney damage, it has huge savings to the health dollar. Just something that I was impressed by the way they've done it is they have a calendar, and they spread the QC. They run QC once a month, and they run EQA once a month. But they spread it across different weeks, so you're getting coverage of the device and the operators. And again, Tony will talk about this as well, but just we've worked with the Qualms people to introduce real-time EQA as well as real-time QC. So once they put their EQA results in, we've already put the expected result in. We've tested the samples beforehand. If they get a red symbol, it's stop, don't do any patients, contact us for advice. And that has improved the precision and the uptake on that program dramatically. There's guidelines which you would similarly use in a lab for the operators, trying to keep it as simple as possible. You know, if you've got a yellow, proceed with caution, but stop, don't do any more patients till you've sorted the problem out. Just a very quick one, Sydney 2010, I was working at St Vincent's. An excavator cut the main cable to the hospital. We thought, okay, the generator will come on. The backup generator fails. We had patients in intensive care, had to be hand ventilated. Operations were proceeding under torchlight. The lab was eerily quiet. You could hear a pin drop, and the staff said, what do we do? We had this in our lab. I said, here's our pathology service till we get power back. We can do blood gases, we can do electrolytes, we can get troponins out there, hemoglobins to our ED department. So it's handy to have one there for other reasons. Sorry, I was fascinated by this article on point-of-care research, and antimicrobial resistance. It's one of our biggest challenges globally, that, due to misuse of antibiotics, we've got all these resistant bacteria, bugs. And this is research happening at the Kids Institute in Sydney. And basically, the strep A has, the antibiotics block its folate production, means it can't grow, it can't replicate. And it's now in a human host. It's tricked the human host to provide the folate for it. But you won't pick that up when you plate it out and do your antibiotic sensitivity in the lab. So they're developing a point-of-care device that will pick up this resistance at the site when you, particularly in our First Nations people, strep A is a very serious problem that affects their renal function. Okay, so just to wind up, don't be frightened of point of care. It's not a threat to you or your careers. It actually will enhance your care to your patients and your interaction with your clinicians. So thank you.
Thank you, Peter. So we've got some questions in that have come, really not specifically about point of care, but a number of questions. So we'll start trying to answer those now. We've got a few minutes. So the first question is, what is the best way to troubleshoot serum indices? This came up in Zoe's talk, but I suspect Peter is the most appropriate person to answer the question. So what is the best way to troubleshoot serum indices, HIL, if reported assay is outside the acceptable range?
If reported
outside
acceptable range. Yeah, and that's a good question. And when we were developing this program, and the manufacturers even said to us, well, what do we do? It's all embedded in the spectrophotometer in many cases. You're doing spectral scans of the material. And what we did detect was that even within a laboratory network using the same analyzer, the same reagents, their indices had been set up differently, but they were using the same cut points to make decisions about accepting or rejecting samples. So Lab A here was rejecting samples, Lab B here was accepting them on the same platform. So it identified inconsistencies as to how their instruments were set up. Even the manufacturers didn't know too much about how to set up the instruments, and we're setting them up differently in different sites. But we have had instances where, certainly on some, I've seen it in real life with Abbott, where the hemolysis index is out or the PNMS index is out, and they contact the manufacturer and replace the photometrics for that analyzer. And it actually fixes other problems. If you're using a extinction coefficient, a factor for your enzymes, you're relying on that spectrophotometer being in good condition, your lamp's right. If you calibrate enzymes every few days, that will adjust as your photometrics start to change. But if you're using a constant factor, which is very common now, you won't notice that unless your QC picks it up or your EQA. So they saw improvements in a range of their assays once the photometrics were sorted as well.
The next question is, if we have certain tests that always show high or low bias in EQA, but still acceptable within the peer group, what else should we do? I'll answer this question later on today, so that will come. The next one is, regarding patient report comment EQA, how would you suggest for labs to best utilise this report in improving laboratory performance? So this is the patient comments program we send out. Really the purpose of that is twofold. One, education, so people can see, given a set of results, how, and some clinical notes, how should that be interpreted? So that's for education. The other aspect of the patient report comment EQA is about standardisation. What labs should do, given the same set of results, the same clinical comments, the doctor should get the same report. So what the report should contain is what's wrong, why, based on these results, and to the clinician, what should I do next? So the purpose of the patient report program is, one, to educate, but also to start to try and get standardisation in the post-analytical phase. So given the same results and the same clinical comments, the patient should get, or the doctor should get the same comment back. The next one is, with regards to point of care testing, is it better for laboratory personnel to be in charge of the analyzer, or can be done better by the clinical staff in clinics or wards? Up to you.
Yes, as I've tried to show during the talk, it's a much better outcome if you're working with the clinicians. If you leave it to them to manage, they're not going to run EQA. They probably won't even run QC. What I have noticed is when it comes to accreditation time, and laboratories in Australia, they accredit their point-of-care networks, and I've seen the ED physicians come to the assessments, to the opening and the closing, and they say, I'm going to do assessments, and they say to me, we could not manage without this in our lab, but they need the quality oversight. So I think it's really important that you work with the clinicians to manage the setup, because they make mistakes. They get it wrong.
One more before we go. This is sort of on a different topic. Some of the samples for urine toxicology were not assessed due to less than 80% concordance. How can we assess the lab performance for this in urine toxicology?
In toxicology, sorry?
Urine toxicology.
Oh, urine toxicology, 80?
Less than 80% concordance, so that wasn't assessed.
Yeah. It's a similar question in our serology and immunology programs as well. We might have 66% saying yes and the rest saying no. We've used 80% as a guide to give us the most confidence. We're not saying that if you're in that, greater than 50% group that you're wrong. We're just saying you should self-assess more, because there's different methods out there, there's different sensitivities. Urine toxicology, there's time of flight instruments, certainly Hong Kong. We see Malaysian labs picking them up. They pick up drugs that we don't even know are there ourselves. The toxicology samples come from real patients. They're often patients that have just come into hospital for urine protein or electrolytes, and we have an expert committee who screens those. They de-identify them, but that's how we keep up with all the new drugs coming on the market, the synthetic cannabinoids, the ketamines, the fentanyls. So they find things there but what we also find is when we send those samples out, we're expecting this, this and this, but some of the very sensitive devices find other drugs. If we get 5 or more, we say that's probably was there. Whether it's significant or not is another story. But yeah, if you're still in that group, the greater than 50% group, it doesn't mean you're wrong. It means that we don't have the confidence to say that the other people are wrong either.
Thank you, Peter. That's all the questions up till now.